Dear students, having worked up a cataract surgery, then we will have to decide the surgical modality which we are going to use in this particular patient, the type of IOL which we are going to implant in this patient, and get his consent and take him through the preoperative preparations. And that is a big exercise which is mostly asked in the examination. So we will go through those one by one. The most important thing which we already touched upon is informed consent. Informed consent is to make the patient understand what procedure is going to go through and what are the usual complications which are supposedly possible in these kind of procedures. So that is an important thing. That is an informed consent, which is a signed statement received from both the patient and his nearest attender who is available. After explaining to him, it should most probably be in the patient's own vernacular. It should be understandable by the patient. Next is we will give him topical antibiotics. Of course, we will give him usually gatifloxacin or moxifloxacin eye drops to be used 4 to 6 times in a day, 1 or 2 days before surgery. This antibiotic, topical antibiotics, is prescribed to clear the conjunctival cul-de-sac of pathogenic bacteria and to keep it clean for the surgical procedure. During just on the day of surgery, patient should have a head bath and clear the whole face should be clean and washed, and the eye which is going to be operated is going to be marked, so that in the operating table that marked eye will be prepared and proceeded with for cataract surgery. And the lens which is suitable for the patient by the A-scan value is also kept ready for the patients with the patient for use. There is also a system of giving 2 tablets to the patient just before surgery, 2 hours before surgery. 2 tablets are given. One is Diamox. The Diamox tablet is acetazolamide tablet. It is given for IOP lowering. We want IOP lowering, and we give a sedative. A sedative is given. A sedative can be like Compose or alprazolam. This tablet is given 2 hours before surgery to sedate and allay the anxiety of the patient, and also to keep his intraocular pressure low. Mydriatics, there is a necessity to use tropicamide plus. Tropicamide plus is the usual mydriatic which is used in most of these patients. This tropicamide plus should be started at least an hour before surgery and applied 2 or 3 times, so that it dilates the pupil very well. And there is also a system of using NSAID drops along with, like flurbiprofen or bromfenac, nepafenac. These are NSAID eye drops, topical NSAID preparations. So along with the mydriatic, if you use these NSAIDs, it is found that the dilatation is kept persistent for a long period of time for successful surgery. Or else through the surgery, we find the dilated pupil trying to constrict, making it difficult for the further steps of surgery. To avoid that, it is better to use mydriatics along with NSAID eye drops to keep the pupil dilated as far as possible during the surgery. The next important decision making is to decide on the type of surgery. So in the type of surgery, we will come from the olden times to the recent methods. The olden times we were using ICC surgery. In ICC surgery, we can only have aphakia because the posterior capsule is totally removed. The whole lens is removed. Anterior capsule, posterior capsule, everything is removed. So that is an intracapsular cataract extraction. Here, the patient intraocular lens cannot be placed because the posterior capsular support is not there. So in this kind of surgery, aphakia is the outcome. It is a very old surgery and it is totally obsolete nowadays. Next is ECCE. In ECCE, the posterior capsule is retained. The posterior capsule is retained, and because the posterior capsule retained, IOL can be implanted. IOL can be implanted into the eye. So that is the advantage of a ECCE surgery. But there is a disadvantage in ECCE surgery. The disadvantage is a big incision is made in the limbus and it has to be sutured. we will have to make at least 5 sutures for closing this wound. This kind of 5 sutures leads to lot of suture irritation, suture infection, suture related astigmatism. All these are unwanted outcomes of this sutured procedure. So from ECCE, we have shifted to SICS. This is the most commonly used surgery. This is the most commonly used surgery nowadays because it is a very cost-effective method. It doesn't need any big instrumentation to do. It is basically a manual phacoemulsification, manually done phacoemulsification without the machine. It uses a very small incision which is made into a tunnel. It is made into a tunnel, and that tunnel is used to enter the eye and do the procedure. So it doesn't need any suture. It is a suture-less surgery. Suture-less cataract surgery is SICS. It is having that much of avoidance of suture-related complications. So it is a very commonly used surgeries nowadays. Next important surgery is phacoemulsification. Phacoemulsification is a machine-dependent surgery where ultrasonic energy is used, and this ultrasonic energy is used to emulsify the lens. It is using a phaco machine, and the phaco probe needs to be inserted into the eye. Once the phaco probe is inserted, it can do everything. It can do emulsification and aspiration of the lens matter. Simultaneously, it can irrigate saline into the anterior chamber, and then a foldable intraocular lens is placed in this place. So this phacoemulsification is very good because it only produces a very thin wound, very small wound, just a 2.8 millimeter wound. 2.8 millimeter wound is created here. That is the advantage. If you take ECCE, it will make almost 8 to 9 millimeters of incision. If you took SICS, it will usually make a 6 millimeter incision. If you think of phacoemulsification, think of a 3 millimeter incision. So the advantage is making the incision smaller and smaller. Femtosecond laser assisted surgery is that femtosecond laser is a special laser which can do certain steps. The most critical steps of phacoemulsification are a rhexis, a capsular rhexis, and a lens division or fracture, lens fracturing. In the divide and conquer technique, division of the lens. Nucleofractis it is called. So these two steps, that is the capsular rhexis and the nuclear fracture, can be nicely done by a femtosecond laser, and done very meticulously, and very pinpoint perfection can be reached by doing a femtosecond laser assisted cataract surgery. Then you will ask me, what is this lensectomy? Lensectomy is basically a surgery done in pediatric cataract. In pediatric cataract, especially cataract of children less than 2 years of age, then you will have to do lensectomy. Less than 2 years, IOL is not implanted. So less than 2 years surgery, less than 2 years, then we'll have to go for lensectomy. Lensectomy is the surgery of choice for less than 2 years. Okay. Now, having decided the method for surgery and having prepared the patient with preoperative medications, then we'll have to start the procedure. Before starting the procedure, we have to anesthetize the eye. Anesthesia of the eye is a very important necessity, because there should be no pain. There should be like what are the necessities after anesthesia is a question. There should be akinesia, that is eyeball should not move. There should be anesthesia, that is no sensation. There should be analgesia, there should be no pain. And there should be an inability to closure. Only the eye should be only open. The eye should not be able to close. The patient should not be able to squeeze his eye close. That should also not be there. So these are the 4 outcomes which we need after a good block. So what block is used? Traditionally, we were using many blocks, but today in modern cataract surgery, the most important and most useful block is a peribulbar block. In a peribulbar block, this is the peribulbar block. Can you see? A syringe is loaded with the solution has 3 components. The solution has 3 components. One is 2% xylocaine, hyaluronidase, and adrenaline. 1 in 1 lakh adrenaline. So this kind of mixture is prepared before for anesthesia. And this solution is loaded in a syringe. Around 4 ml of the solution is loaded in a syringe, and the needle is injected into the suborbital, intraorbital, perorbital space. And once it goes into the peribulbar space, once it goes into the peribulbar space where it is here, that is this inside the muscle cone, this is the retrobulbar space. Remember, retrobulbar space is this, and this is the peribulbar space. Remember, this is the peribulbar space. This peribulbar space, once you inject, it is safe, because previously we were trying to go into this retrobulbar space where the optic nerve can get injured, or we can inadvertently perforate the globe. So globe perforation and optic nerve injury are two possibilities which are totally avoided by a peribulbar procedure. And once peribulbar injection is given, it gets you all these four end points. The end points are analgesia, akinesia, anesthesia, and inability to close the eye. Previously, when we were using a retrobulbar injection, the inability to close the eye cannot be obtained by a retrobulbar injection. So it has to be separately done. This is called a seventh nerve block. The seventh nerve has to be separately blocked in a retrobulbar procedure. But now that is slowly avoided, and only a peribulbar procedure is given. So present day, this seventh nerve block is not needed. This kind of seventh nerve block is not needed anymore. A normal peribulbar block can get you good anesthesia. But if you are a very experienced surgeon and you are going to do a phacoemulsification with the least manipulation of the eyeball, then even a topical anesthesia is enough. We can just apply drops of 4% xylocaine. Here it is 2% xylocaine. Remember, injectable is 2%, but topical is 4%. We have to use 4% xylocaine, and once you use 4% xylocaine, we can get proparacaine, we can get good anesthesia, and that can be used to do cataract surgery. Okay. So with that, we have gone through what is the preoperative preparation the patient goes through, what are the main consent and medications which will be given to the patient before surgery, and how the eye will be marked properly for surgery. Then what is the block room doing? In the block room, what are the methods we follow to produce good anesthesia for the patient to undergo a cataract surgery? Thank you.